Welcome. Thank you for joining us for Take Action Group, which is a partner program of our organization, the Epilepsy Foundation of Greater Los Angeles, and the Epilepsy Center of Excellence at the West Los Angeles VA Medical Center. My name is Rebecca Hollowell, and as the Assistant Director of the local Epilepsy Foundation, and on behalf of our partner and sponsor, we're excited to be offering this program to veterans with epilepsy and their loved ones, so you may learn how to better navigate the VA system and empower you with knowledge to aid you on your quest for seizure freedom. Today we have Dr. Sen-Gupta from UC Irvine Health discussing medications from A to Z. Dr. Sen-Gupta will speak for the first 20-30 minutes, and you can follow his presentation now online or visit veteransandepilepsy.org. There will be an opportunity to ask Dr. Sen-Gupta questions following the presentation, so please hold all questions until that time, and I will certainly let you know when to ask away. Following the Q&A portion, we encourage you to remain plugged in to participate in further discussion being led by Lorette Hayden. Lorette Hayden is a licensed marriage and family therapist with extensive familiarity with epilepsy. This discussion period with Lorette will provide you the opportunity to have an open conversation with others affected by epilepsy, including loved ones and caregivers, to gain support and share information. One thing to note, we are recording as of right now, and will be recording when Dr. Sen-Gupta is talking about his presentation. We will not record the Q&A or the discussion period, and you'll actually hear a chime when that recording has concluded. Thanks again for joining, and with that, I'd like to turn it over to you, Dr. Sen-Gupta.
Okay, thanks, Rebecca. If we can just start with the first slide then. Okay, great. So basically we'll be going over seizure medications A to Z. So when I initially got this topic, I thought, oh my goodness, how are we going to fit all the meds from A to Z, because that's what the talk was entitled. So we will do our best to get through as many different types of medications as possible. Please understand this will be just a general overview because there is so much to kind of cover. But I'd like to just point out that this presentation will be based on basic principles. So we'll talk about broad brushstrokes about basic mechanisms of action of seizure medications, where certain medications might be particularly helpful, and we'll also provide information on some side effects and potential cautions. One thing that I do want to point out is that I'll be speaking from my own clinical practice, and some of the explicit FDA indications might not be specifically met for certain medications. So we do often in epilepsy and in medicine in general use some medications off-label as common practice, even if the FDA labeling was not that way. So I just would like to point that out so that it's borne in mind in case there's any question about why something I'm saying doesn't necessarily match specific FDA labeling. Next slide. So we'll start off by pointing out basic pearls, just things that we keep in mind as we approach seizure medications. And there's actually a bunch, but keeping these considerations in the back of our mind really helps us to tailor seizure medications for our patients. Next slide. So first principle is that we try to use the least amount of medication at the lowest possible dosages that still provides full seizure control, because that minimizes side effects. If we do have to go up on medications for seizures, we try to max out one medication first before we add a different medicine, because that way we don't end up with several different medications at below therapeutic dosages. We also consider whether a medication requires us to check blood levels, particularly during pregnancy where seizure medication levels may significantly decrease, or we can sometimes use medications where we can go by strict milligram dosing and don't actually have to check levels. So that's something we also need to keep in mind. Next. We consider the impacts that seizure medications may have on other medications a patient might be on. In particular, if there's female patients on oral contraception, there are particular medications that can decrease concentrations of those and make it less effective. Other medicines, such as if someone is on an anticoagulation, a blood thinner called warfarin, can be decreased by certain liver-inducing medicines for seizures. And if there's there can actually be competition between different types of seizure medications, and we have to keep that in mind as far as what adding or subtracting one would do to the levels of another. When we are transitioning one seizure medication to another, so say we're switching one medication A to medication B, we usually will add medication B while medication A is still on board, and then we will try to slowly taper off of medication A and increase medication B. We don't usually stop one medication and then just add the new one. That's because the new medication can take some time to get therapeutic, and also we want to give a chance to make sure the patient's tolerating the next medication we're going to switch through. Another thing we have to keep in mind is other existing conditions. There are certain seizure medications that may not be so good if someone has underlying depression or anxiety. On the other hand, there might be other medications that are really good if someone has underlying depression and anxiety, and we want to make sure that we pick those medications. If someone has the potential to have kids or is pregnant, there are a whole set of other considerations we need to think about. And there's other medical conditions that we bear in mind, such as migraines and so forth, when we consider what medication could be helpful. Okay, next slide. If we are adding seizure medicines, say someone's seizures are not controlled fully with a particular medication, if we do need to add another medicine, we try to add one that has a different mechanism of action. That is, it will try to prevent seizures by a different means than the previous medication that a person was on. This is helpful because it allows synergy of having more than one medication on board, and it also helps to minimize side effects because it's not acting on the same pathway. In addition, we consider if the seizure types are focal onset, that is, if the seizure appears to start in one area of the brain, or rather one hemisphere of the brain, and then spreads potentially to the other hemisphere if it secondarily generalizes, versus if someone has a primary generalized epilepsy, which is where patients will have immediate generalization that is spread through both hemispheres of their seizure activities. And this is important because there's some sodium channel blocking agents that can worsen an underlying generalized epilepsy but are fine for seizures that start focally with or without secondarily generalizing to involve both aspects of the brain. Okay, next slide. So this is just a snapshot view. I'm not going to go through all this, but this is just a snapshot view of some of the considerations that we keep in mind when we add seizure medications. So there's things as far as liver interactions. Does someone have migraine? How often do we want to dose? What are some of the side effects? What happens as far as people who might be of childbearing potential? And so those index cards on the left that I've gotten from eMedicine actually do a great job of describing some of these considerations. The ones that I would add are on the right, which is that if someone's got underlying depression or has mood issues and would benefit from mood stabilization, there are certain medications as listed that could be helpful for those instances. For someone who may be on the verge of having a child or is pregnant, well, hopefully by the time they're pregnant, they're already on one of these medications. But those are some medications that have some relative safety data for use in pregnancy. And so we like to try to have that on board if possible for someone who's pregnant. And especially for people who might be getting pregnant, we oftentimes will give folic acid even before, because about 50% of pregnancies in the United States are unplanned, and folic acid helps to develop the fetal nervous system and helps to maybe to protect it from some of the effects of these seizure medications that might be causing problems in the first couple of weeks after the fetus is developing. Some other pearls that we have to keep in mind is that all seizure medications, even the ones that are supposed to be good for mood stabilization, can have this risk of worsening mood. And so we have to counsel patients that we don't know how they're going to react to medicines, and that if their mood is significantly worsening, they do need to let us know right away so we can adjust that medication or try a different one. It's important to keep in mind that all seizure medications can have cognitive side effects. That is, someone can feel like they're just not functioning as fast or as quickly, or feeling a little bit down as far as their energy. And this is because there's no seizure medication that we have currently that will act just on the place that's causing the seizures to happen. They will act on the entire brain, and so we have to keep in mind there can be these cognitive side effects. Next slide. So a lot of the following slides are actually right from the Epilepsy Foundation website. There's a great clickable medication list that has information on multiple seizure medications, including mechanism of action, what the dosing is, what the indications are, what to watch out for. And so I would refer definitely to that site for a more extensive overview. I did take also some excellent figures from this eMedicine article, which I've also cited and is actually a very good read for mechanisms of medications. Next slide. Okay, so that is one of the snapshot slides from I believe the Epilepsy Foundation website, and you can see there's numerous types of seizure medications, and in this case it is listed A through Z. We'll get through a fair amount as we can, and again, we'll keep the general principles in mind as we go forward. Next slide. So this is kind of mechanistically what happens with seizures versus seizure control. So seizures happen because there's increased excitability and increased synchronization of neurons, that is the brain cells, and when these neurons fire in populations in a synchronous orchestrated fashion, that's when we get seizures. So things like excitatory synaptic potentials, the entry of sodium or calcium into the cell, these are things that can make it more likely for us to have a seizure. Whereas if we're able to inhibit neurons from firing to some extent, if potassium leaves the cell or if chloride enters the cell, then these can help us as far as controlling seizures. So a lot of the medications that we'll discuss will be sodium channel blocking agents, and rather stabilizing the sodium channel in a block configuration agents. And then there will also be some agents that block calcium, some agents that help us to get more chloride into our cells. But all of this is attempting to be done in an attempt to tip the balance towards seizure control. Next slide. Okay, so we basically have a large soup of things to go through, and we're going to try in some form to organize these medications by some mechanism. All right, so next slide. This slide shows us, again, some of the basic categories, the sodium channel, calcium channel blocking agents. Then there's GABA-ergic. GABA is an inhibitory neurotransmitter, so in the brain it allows for basically for inhibition of excitatory activity, and it also causes chloride to come into the cells, so it helps a lot as far as trying to minimize potential for seizures. Glutamate is an excitatory neurotransmitter, so having glutamate on board will actually make it more likely for seizures to happen, and so there's certain agents that will try to block some of those receptors to try to make it less likely for seizures to occur. And there's some other medications listed as well. What I want to point out is you'll see that some of the medicines listed have multiple arrows because not all medications necessarily have just one mechanism of action. There are some that will have multiple. And so we'll focus, for the purposes of the rest of the slides, we'll focus on the major activities that each of these seizure medications has, and then we'll try to sort of add on little informational points about any other additional activities they have. But for the purposes of the rest of the slides, I've broken it down by the major activity that these medications have as far as their mechanism of action. Next slide. Okay, so sodium channel blockers are the most common mechanism of action of seizure medications. On the slide below, I've shown what happens to a sodium channel as it cycles between open, which is the middle slide. So when the channel is open, the sodium ions flow right down into the channel and into the cell. Very quickly, though, this ball, it's called a ball and chain mechanism, this ball, which is a set of peptides and proteins, will quickly try to block off the channel, close off the channel so that no further sodium can enter the cell. But then that ball ultimately gets released as the channel is being closed, and then actual closure of the channel itself occurs. So there's this so-called fast inactivation which is where so there's two types of inactivation, basically. This fast inactivation and a slow inactivation. And the sodium channel blockers bind to the sodium channels in either the fast inactivated or slow inactivated states and attempt to prolong the duration for which the channel is rendered inactive, thereby allowing less sodium to enter the cells. Okay, so the fast inactivation is the ball and chain, and the majority of is the ball and chain, and it's depicted in the inactivated channel, which is the third one on the right. And so the majority of the medications will bind to and stabilize the channels in that state. Whereas in slow inactivation, this is likely due to rearrangement of the channel pore itself. So it's kind of as the channel is closing off, like we see in the closed state, and it will stabilize that state where the ball has kind of fallen off, but the channel configuration itself for the slower inactivation gets stabilized by the medication so as to prevent further rapid flow of sodium channels into the cell. So bottom line is that sodium is being blocked in some way from entering the cell by interactions with the channel. Next slide. Okay, so multiple medications that I've listed there act on the fast inactivation pathway. There's really only two medications, Lacosamide and Eslicarbazepine, that act in the slow inactivation pathway. Next slide. Excuse me. So again, this is listing the medications that act on the fast inactivation pathway. On the bottom, you see some of the medications listed, and that inactivation gate that's being pointed is actually sort of the ball in the ball and chain mechanism, and that's the state in which these medications act on these channels. Next slide. Okay, so we'll start with these medications that act on the fast inactivation pathway for sodium channels. First is this medication called Phenytoin or Dilantin. This is one of the older medicines, one of the most commonly used in the world because it's older and also cheaper at this point. And Phenytoin is very commonly used in multiple countries. And this is an older medicine. We can give it for IV if we need to for acute seizure control. And it's used for focal onset seizures, so seizures that start in one hemisphere and then potentially spread. However, there's multiple possible side effects, including that we can often increase liver enzymes and increase metabolism of other medicines that are cleared to the liver. And part of this is that vitamin D levels can decrease when we give Phenytoin, so we have to follow vitamin D levels. Vitamin D is important for getting calcium into our bones, so we have to follow that. And sometimes we can even consider doing what's called a DEXA scan, which looks at the status of bone health and gives us a sense of if someone's developing osteopenia or osteoporosis with long-term use. There's multiple precautions for Phenytoin, including the osteoporosis. People can have tremors. There can be gum and teeth issues with long-term use. People can develop issues as far as numbness in some of their nerves with the Dilantin. And there can be increased liver enzymes like we talked about. It can cause increased metabolism of oral contraception, and in fact, ideally we like not to have this on board if someone is going to get pregnant because there are possibilities for fetal effects, which I'll show later. Okay, next slide. Valproic acid or Depakote is also another older but common agent, and we can also give this IV if it's necessary. This has a broader spectrum of action, so it can often be used in generalized seizures as well, in addition to focal onset seizures. We ideally really don't want to have this on board in pregnancy because it can cause fetal neural tube defects. Multiple other side effect potentials and considerations are similar to Dilantin. The only exception is that Depakote, instead of increasing the metabolic activity of liver enzymes, decreases it. And so what that means is other medicines that are normally cleared by the liver may end up with higher levels if Depakote is on board. Okay, next slide. These are some examples of some of the fetal effects that can happen with seizure medications. On the left is something called fetal Hydantoin syndrome, which can happen with Phenytoin. Cleft lip and palate can happen with multiple seizure medications, including Dilantin and Depakote. And spina bifida, where the spinal cord isn't fully encased and there's a defect, that can often happen with Depakote, but other with Valproic acid, which is Depakote, and other seizure medications as well. I apologize. I've been using sometimes the generic name and also the trade name for the medicines in the talk, but in the slides I just have the generic name. So I'll just stick to calling all the medicines by their generic name going forward to keep it more consistent. Okay, next slide. Lamotrigine is a broad-spectrum seizure agent. It's available only orally. This is one where we have to follow the levels of the medicine. There's not a set milligram dosing that will necessarily work for every patient. The Valproic acid and the Phenytoin are similar in that regard as well. The dosage of lamotrigine has to be increased over multiple weeks and slowly. It's usually a very well-tolerated medicine. It's great often for people who have other mood issues, can be relatively safe in pregnancy, but it does have the potential to cause a rash, which, if left unchecked and untreated, can progress to become life-threatening if it involves the mucous membranes. So that's why we always go up slowly on this medicine to make sure that people are not developing such a rash. Other considerations are that you can get dizziness and mood changes. Oral contraception, if somebody is on it, can decrease the lamotrigine levels, but the reverse does not actually apply. Overall, it's a very well-tolerated medicine that we commonly use in people with mood issues just to get dual effect for seizure control as well as mood stabilization. Next slide. Okay. Now we have carbamazepine and oxcarbazepine. These are similar meds because oxcarbazepine is a derivative to carbamazepine. These are also sodium channel blockers that are used for focal onset seizures, and these medicines act on, again, the fast activation pathway. And these medicines can potentially worsen underlying generalized epilepsy, so we use them in focal onset seizures. These will cause liver enzyme induction, so just like the Phenytoin, we have to watch out about drops in other medicines that are cleared by the liver. Keep an eye on the vitamin D levels, again, possible for DEXA scan. We have to follow levels of these medications. There's not, again, a strict milligram dosing that will be effective in all patients. One thing to watch out for with these medicines is that they can cause sodium levels to drop, and that in itself can cause its own set of side effects, including potential for seizures, so we have to keep an eye on that. These medicines are relatively safer in pregnancy and there's more experience with them. However, in pregnancy, the metabolism of these medications is significantly increased and the clearance can be increased as well. And so we have to oftentimes give higher dosages and check monthly levels in order to make sure that we are appropriately treating patients in their margin of safety and keeping them in the margin of safety for the levels during the pregnancy. There's a specific genotype where, especially in Han Chinese patients, where there may be an increased risk to get the Stevens-Johnson's rash. The Stevens-Johnson's rash is the same rash that can be life-threatening in lamotrigine, and so we want to be relatively cautious with using these medications in patients of East Asian descent, specifically Han Chinese. Okay, next slide. This is an example of a DEXA scan. So this is the scan that we do if someone's been on, well, we can often do it if someone's been on an enzyme-inducing medicine like carbamazepine, oxcarbazepine, dilantins, sometimes even Depakote due to poor vitamin D absorption can result in issues with bone density. And so basically this is a dual X-ray scan that allows computation of bone density, often looking at the femur at the hip. Looking at that bone head, we're often able to see, are there any signs of accelerated bone loss, and is there something that we need to do about that as far as maybe considering a different medication, adding vitamin D if possible, adding calcium supplementation and things like that. Okay, just an example of that scan. Next slide. So now I'll move on to Topiramate and Zonisamide. These are technically having sodium channel blocking agents, but they're a broader spectrum. They can be used for focal or generalized seizures. Topiramate also has actions of augmenting GABA, which is the inhibitory neurotransmitter activity. It can have actions of trying to hamper activity at glutamate receptors, so it basically minimizes excitation that way as well. These two medicines may have good effects as far as patients with migraines because they may have some migraine-related effect as well. They do interact with an enzyme called carbonic anhydrase, so patients end up with decreased bicarbonate in their blood, and what that can do is cause a metabolic acidosis, and people can feel like they're numb and tingly. That often resolves. There is a possibility to get kidney stones with some of these with these agents, and so we always encourage good hydration. If someone has ever had problems with increased eye pressures on these medicines, if someone has ever had problems with increased eye pressures in the past, we often use great caution with these medicines because these medicines can result in what's called an angle closure glaucoma, where basically the eye pressures can get very high, and so we don't want to cause that. Other things to consider with these meds, so there can be word-finding issues, and people can often feel somewhat more slowed on these medicines. We do go up slowly on the dosages and try to minimize some of these side effects. And it can be a very well-tolerated medicine sometimes for patients who have migraines as well as seizures. It can be a really good as far as trying to hit both of those aspects. Next slide. So this is a medicine called Felbamate. This is meant for focal onset seizures and generalized seizures associated with this Lennox-Gastaut syndrome, which is a very debilitating syndrome where patients who, as children, will have severe developmental delay and these ongoing seizures, oftentimes with drop attacks, where they'll just drop and lose muscle tone. And so there's multiple mechanisms of actions here beyond just sodium channel that may help, including blocking glutamate. But this is a very powerful medicine, and it has the potential to cause some liver failure. It has the possibility to cause side effects, including liver failure, and that's why we have to really closely monitor liver functions. People can get insomnia and irritability. Oftentimes you have to take melatonin to try to go to sleep. There can be complex interactions with other seizure medications. Typically, this is not a first-line medication. We consider it as one of the big guns sometimes and save it for later if someone really is having ongoing seizures despite other medicines and really does need something stronger. The good news is by monitoring closely, we do minimize a lot of the risk, but we do have to monitor very frequent labs several times a month, actually every couple of days at the beginning, then every couple of weeks, then every month, and then maybe every couple months. But it's kind of an involved process to get there. However, in instances where everything else has not really worked seizure medication-wise, this can be a good option to consider. Next slide. It's a medicine called Rufinamide. This is specifically meant for seizures in Lennox-Gastaut syndrome, particularly these drop attacks, which is where people oftentimes as children will be having these seizures where they'll have uncontrollable falls, often with injuries, will require a helmet for that. The complete mechanism of action is not known. The effect on just the voltage-gated sodium channels doesn't account for this unique spectrum of action. So we don't, again, know why some of these medications completely work, but we have noticed these trends, and in particular, Rufinamide is helpful for patients with drop attacks. Other things to watch out for, which is kind of standard for some other seizure medications, is drowsiness, dizziness, nausea. In this case, there might be interactions with other medications cleared by the liver as well. Next slide. Okay. So now we're at the point where we can talk about the two medicines, Eslicarbazepine on this slide and Lacosamide on the next slide, that are these newer agents that act specifically on the slow inactivation pathway of the sodium channels. And so Eslicarbazepine is a derivative of Carbamazepine and Oxcarbazepine, and because it acts on the slow inactivation pathway of sodium channels, it may be a good addition to other fast sodium channel blocking agents, because even though they're both acting on the sodium channel, they're acting on different aspects of the inactivation pathway, and so there can be synergy between the medications. This particular medicine, Eslicarbazepine, does have fewer interactions through Carbamazepine and Oxcarbazepine. However, there are still some interactions that we do have to be aware of. Oftentimes for this medication, we have daily dosing milligram regimens that we can utilize, And often we just go on the basis of whether a person's seizures are controlled, whether they're having side effects, as opposed to necessarily following strict levels like we do for carbamazepine and oxcarbazepine. The caveats as far as continuing to monitor sodium levels and the potential for rash in specific populations still does apply. Okay, next slide. Okay, and the lacosamide is, again, a newer agent. It is selective on the slow activation pathway. It is IV available, so sometimes for people who have ongoing acute seizures, we can just load it and go forward. There's minimal interactions with other meds, which makes it helpful, and we do have to decrease the dosage in patients with liver impairment. Next slide. Okay. Now, it's just one calcium. Well, actually, there's a couple of calcium channel blockers we'll briefly go over. As you can see, ethosuximide is one that blocks the calcium channel. Valproic acid, in addition to sodium channel effects, also has calcium blocking effects. So you can see, depending on the sources where we get some of these slides and pictures, we may see different meds for different actions. And so it's not just as clear-cut as we would like to think. Next slide. Okay. So ethosuximide is often a drug of choice for this syndrome called childhood absence epilepsy. This is a generalized epilepsy syndrome where patients will have staring spells, sometimes with eyelid fluttering, but come back to baseline very quickly afterwards. It's thought to be probably a genetic-related epilepsy and is very well treated by this ethosuximide medication. Other medications that are potential calcium channel blockers are gabapentin and pregabalin. These block something called the alpha-2 delta ligand on the calcium channels, but they probably have mechanisms of actions at other channels as well. It's not quite clear, actually, how these two medicines work. If someone has neuropathic pain, that is, they're having numbness, tingling, and pain due to nerve damage, these can be effective medications to use, and they may have some effects as far as, for the gabapentin at least, for helping with anxiety as well. Weight gain can happen as a consequence of pregabalin, so one needs to keep that in mind. Next slide. Okay. There's medications that enhance activity of this neurotransmitter called GABA. GABA is this neurotransmitter that will bind to the GABA receptor, and what that does is that it causes chloride to come into the cell, and that calms the cell down, causes an inhibitory effect. Okay, next slide. So there's kind of there's several categories, but the big categories of medications that facilitate GABA are benzodiazepines, which increase the frequency of the GABA chloride channel opening, and there's barbiturates, which increase the duration of the channel opening, but both serve to basically increase chloride entry into the cells. There are multiple benzodiazepine medications that are rapid acting and that are used just as needed if patients are having clusters of seizures, or if someone is having ongoing seizure activity to try to break that. We often will give an injection of lorazepam or diazepam. Some longer-acting medications that are benzodiazepines are medicines called clobazam and clorazepate. These can be used as scheduled long-term medications, with clobazam often being helpful for drop attacks and seizures that seem to be worse around the menstrual cycle. Barbiturates are a whole class in themselves. One of the most common agents there is phenobarbital, which is older agent and broader spectrum, and like carbamazepine, oxcarbazepine, and phenytoin can increase the liver enzymes, and so we have to watch out for interactions in that regard. Next slide. Okay, a couple others here are one that prevents the uptake of GABA. So after GABA is released into the nerve terminal, it is reuptaken into the releasing nerve terminal, and so its activity stops. This tiagabine medication blocks the uptake, and there's another medication called vigabatrin, which pretty much blocks the GABA from being broken down and is largely used in infants with infantile spasms, which is a pediatric epilepsy syndrome. Some cautions are that with all these medications, they can cause sedation because they're acting on GABA. There can be possible irritability as well, and we have to think about liver function sometimes because a lot of these medications are cleared through the liver. So if there's liver impairment, we have to adjust the dosages, always consider interaction with other medications. Next slide. Okay. Then there's these new, other medicines. These are listed under other on one of the prior slides as far as mechanisms of action. These are brivaracetam and levetiracetam. These are broad-spectrum agents. In practice, we do use them clinically for focal or generalized epilepsies. They bind to this receptor called SV2A that seems to be important for calcium-dependent neurotransmission to occur. And so presumably by interacting or helping to block SV2A, presumably by interacting with SV2A in some form, they are minimizing ultimate calcium-related excitatory effects. The advantages here are that these have pretty minimal interactions with other medications, and they don't cause, to a great extent, enzyme induction or inhibition in the liver. So this helps us to dose them for patients who are on multiple other medicines. In addition, we can often get these medications to a good dose pretty quickly early on without having to go up slowly like we do for Lamotrigine. So in practice, this day and age, levetiracetam is often used as a first-line agent. However, we do have to be careful in patients who have underlying mood issues like depression and aggression. For the small percent of people who have that side effect, they can have it pretty pronounced. They'll feel really depressed. They may get really irritable or aggressive. At that point, we don't want to use that medicine. We want to use something else. The brivaracetam may potentially have less mood effects because it's more selective for the SV2A receptor. Levetiracetam has some effects on another receptor called AMPA as well that may explain some of its mood effects. It is noted that levetiracetam dosage has to be adjusted in renal impairments. Okay, next slide. Okay. Some other medicines. So AMPA is a glutamate-based neurotransmitter receptor and is excitatory, and so perampanel selectively blocks these AMPA glutamate receptors. It's a broad-spectrum agent, can be very effective and powerful. It's one of the few in this class that has direct sort of effects exclusively on AMPA. And the problem, though, that we can sometimes run into is that because AMPA is important for us to maintain our mood, people can have mood issues, including aggression, on this medicine. So we have to be really careful and counsel patients to watch out for that. Some hormonal medications, progesterone does have some effects for this inhibitory neurotransmitter called GABA and can be used in certain instances of seizures that are worse in relation to the menstrual cycle. So there's progesterone lozenges that can be given to patients who have menstrual cycle-associated seizures. It can cause some bloating and irritability. We have to be attuned to that. Next slide. Okay, we're almost nearing the end. I know I've gone slightly over time, but I think it's just one or two more slides, and then we're done here. So I know I've gone over a lot. Hopefully I've been able to impress that there are lots of considerations that we as epileptologists have to keep in mind when prescribing medications to our patients. The big ones, though, I think, are just summarized in this slide. So in my case, I look for circumstances where dual effects in addition to seizure control can favor certain agents over others. So I always try to see, are there other factors that make particular sets of medications not desirable, and are there circumstances that make a particular set of medications very desirable for a particular circumstance? If there is no such dual effect need, I will often start with levetiracetam because it's simple, it's easy to get to good therapeutic dosages. We often don't have to check levels or follow them. And so I often start levetiracetam for new onset seizures. And then if needed, lacosamide can be a good option as well because it has minimal interactions. But we always have to consider other medications if our basic shooting from the hip approach doesn't work out for our patients. And if someone continues to have ongoing seizures despite two medications at good dosages, then we do have to do further workup to understand why they're having seizures and really strongly consider, might they be a candidate for epilepsy surgery or a nerve stimulator or something to that effect to try to help with their seizures in ways medications can't. So bottom line, just to recap, there's sodium channel blocking agents, which the vast majority of the seizure medications do. There's also calcium channel blocking agents. There are glutamate blocking agents. And the goal ultimately is to get cells to a more inhibited state without causing tremendous side effects, and also to an area where we can appropriately fully control seizures. Next slide. Okay, and I believe that was that. Thank you.